to Focus on Health, a series of educational programs highlighting current health issues sponsored by the Department of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. Today's topic is population health, and I welcome Kathy Fiedler from Peninsula Regional Medical Center.
Hello.
You are Executive Director of Population Health there, and of course you have many credentials, one of which is you have your doctorate in nursing practice, and you also are board certified as a nurse executive.
Yes.
So very impressive.
Thank you.
And of course you're a former student of mine. I'm a bit biased on your abilities, but I know you're doing a fabulous job in what is a fairly new position at the hospital with being Director of Population Health. So I guess the big question is, describe for our viewers what that means. What is population health and why did it come about?
So population health has really always been what we think healthcare should be. It's the ideal state. It's everyone talking, everyone working together to improve the health of all the patients and the community that we serve. What we found over time is we've developed silos. The hospital does a very good job taking care of the acute care situation. Individual family doctors do a very good job with their patients. Specialists do a very good job with their patients, but we haven't all been talking. And this fragmentation, this brokenness has been going on for several years. And finally, we as a health system has realized that to be able to do this, we have to improve communication. So at the root of it, it's a way to communicate between community services, providers, hospital systems, and other systems of care in our community.
So it's looking at people rather than individuals, but a group, and how to best serve a community. Is that one way to look at it?
It is. We get down at the end of the day to the individual patient, but it's really seeing where are the needs in this community, what are the populations that we're not doing a great job with, and how can we do that better?
I know we did want to talk a little bit about how it came about to be an emphasis in care, and I think we decided that we should talk a little bit about the history of healthcare and reimbursement for such.
Yeah, so PRMC has been around for about 119 years, and as a hospital, hospitals get compensated for a person coming in and spending the evening in the hospital getting their acute care needs met. So really having a patient in the hospital is how hospitals made their money. Same with a provider, family practice doctors, specialists, they get provided for everything they do. So it's really on how much work are they doing, how much revenue are they generating, that's what's making them money. What we find is just doing more and doing more and doing more isn't always the answer. And so we've had to take a step back. Specifically in the state of Maryland, we're under a very special waiver, very different than all other 50 states, which says here is a global budget for you, Peninsula Regional, and we'd like you to spend it very well and do the best that you can with this salary for the whole year. So imagine in your house you get one bucket on January 1st, and taking care of all the patients that we have to take care of, doing all the things that we need to do is how we can work with that budget. What the state of Maryland has also said is, but we don't want you to do that by not taking care of people. We want you to improve the health of the community. So we're going to give you a little extra money to increase your resources, to increase maybe nurses and other multidisciplinary team members like social workers, physical therapists, pharmacists. How can we use all those roles in the community to help take care of the whole community and not just the patients in the hospital?
So it sounds like it's about efficiency with the dollars that are given, and it's a fixed amount, a budget.
It is.
Essentially. And I know PRMC is a nonprofit.
We are, and we struggle. We want to do the absolute best for the patients that are here inside the hospital, but outside the walls of the hospital, it's very important as well. Hospitals are really set up to take care of acute needs, and oftentimes there's so much that can be done at home or maybe in a skilled nursing facility, maybe in a rehab facility that has much better outcomes because hospitals have a lot of sick people. We can get each other sick by being in the hospital. So keeping patients where they have family to support them, where they have loved ones that are watching them 24/7 in a very different way, helping to improve their health is much better than sitting in the hospital.
Right, and I know there's insurance constraints on that, correct? On how long you can stay in the hospital for a certain illness or whatnot, and it is more efficient to get people back into their homes for the most part, not always.
For the most part. And, Medicare is the big one that everybody knows about, but Medicare is very specific about their rules about what there are benefits for and what there are not. And oftentimes patients come into the hospital and Medicare says, no, we're not going to pay for this. So the hospital is now at risk for some of these things. Oftentimes the hospital, we are a not-for-profit. We do a whole lot of charitable work to support patients, but we know that much of their care can be can happen at home, can happen in a skilled nursing facility, and we work very hard with our team to help set that up.
And we'll get to that because I think there are interesting ways to link the hospital with community-based resources. So before we get to that, what are some issues going on in the healthcare environment that have prompted this push towards population health, besides some of the reimbursement issues?
A lot of it is we have the highest costing health system in the world of all other countries, yet we have a lower lifespan. So patients in other countries live much longer and the per capita spending is much lower. So we're not very efficient. We're not doing a good job. We have, although we have short lengths of stay or longer lengths of stay, and other hospitals have shorter lengths of stay in other countries, they still have better outcomes. We have more obesity in the United States than other countries. We have more chronic diseases in the United States. So for all this money that we're spending, it's not helping. It's not getting our country better and more healthy.
And of course, we have an aging population, higher percentage of chronic illnesses that have to be managed, not only in the hospital, but send them back home and hope that they can manage better and prevent that next readmission. So it's quite complicated. And I guess overall you're saying there's just a lack of coordination of that care between.
There is those transitions of care from the acute setting to maybe a skilled nursing facility, maybe back to my primary care doctor. We hear many times the primary care doctor was unaware that a hospitalization had happened. The specialist didn't know that a primary care provider had changed medicines. So connecting those dots and making sure that that communication, once again, it's the root of everything oftentimes, making sure that I talk to you, that you talk to that next person, that the whole family is aware of the care plan, that the primary caregiver for that family member is aware of the care plan. That's the important piece to make sure that everyone gets better and there's better outcomes.
So I guess most hospitals are going down this road of looking at it more in a population health sense, partly because it seems reactive to things that are going on with reimbursement and so on. But how is it proactive? Is there anything about it that you feel is being proactive in preventing problems down the road?
I think what we're doing, especially in this community, we are very fortunate. We have the largest healthcare system here in this area. We are very much embedded in the community. We're part of many of the events that go on, in much of the charitable giving that goes on, and also we have many of us that work at PRMC support many of the faith-based organizations, the other community services. But what we are doing as an organization is really making ties with MAC, with Lower Shore Clinic, with the health departments. We're all talking together about what can we do the best to support these community members. I think sometimes there's lots of services out here in the Salisbury, Wicomico, Worcester, Somerset, all these communities, but we don't know it very well or we don't use them very well, and that's what the hospital is really working hard to do, is how can we build these relationships much better so that we can help patients know what's out there. I know one of the big things that we've been working on lately is a relationship with MAC. They have a beautiful chronic disease self-management class. They offer them in many locations. It's a Stanford program, so it's evidence-based, and the outcomes are amazing. And so we're working more and more with helping patients understand on the inpatient side, hey, here's a resource out there. And that simple bit of communication has already helped change many people's lives.
I know, that's very good. Awareness is good, having the knowledge that it's there, and then you got to hope people access it and use it. But with a little encouragement, something can go a long way with that. Tell me, before we get into some of the specific facets of this, I want to mention, as you know, PRMC is switching over to a different company for their electronic health record, Epic, which is very well regarded across the country. How is that going to facilitate what you do?
What that will do, what Epic does, is it allows a couple things. Number one, everything that's happening on the inpatient side for our nurses who actually work more in the outpatient arena, they'll be able to see everything inpatient as well as all that connection of dots between their care coordinators on the outside. Patients will have an opportunity to sign up for MyChart so that they can have all their medical records, they can see them, and they can know that any specialist, any primary care, any hospital that they go to would have those same medical records. That one of the biggest things that's in that would be your medication list. So that would follow you. I know I started off as an ER nurse and patients would come in and the first thing I would ask is, could you give me a list of your medicines? They would always say, well, my doctor has them. I said, I know, but we don't. And it's not that the doctors didn't call ahead, they did, but that's so many, they have it in their electronic medical record, we would have stuff in ours, and they don't always talk to each other.
Right, plus we know it's not just what you're taking that's prescribed, it's things you take over the counter, any herbals, vitamins, those kind of things, which are very popular right now. So it would be nice if we had a system, and for a while there that was the goal overall, and it looks like we're getting a little closer to that across the country where people are going to be able to access your record, of course with all the confidentiality concerns addressed, that you'll be able to have your record accessed by different practitioners depending on where you are or where you need health care. So I think that's all good news.
It is.
So tell me then specifically, you mentioned nurses, care coordinators. Tell us a little bit about that and how that is going to fit into this puzzle.
So one of the big pieces Peninsula Regional has been building over the past couple years is a transitional care team. So a couple years ago they started with just a few nurses working on patients who we knew were at greatest risk of coming back into the hospital, and that would be folks who have heart failure, renal failure, pneumonia, some sort of infections like sepsis, and COPD. So we know that those patients are more at risk because of the diseases that they have. So this team started working with those folks. They would have a case manager handling their case throughout their stay, but then this nurse would come and meet them before they left, talk to them about the importance of a post-discharge follow-up, how important that follow-up visit, either with your specialist who had taken care of you inpatient or maybe your primary care doctor. If they didn't have a primary care doctor, they would set that up and make sure that visit happened pretty quickly, within 7 days, knowing that these people most at risk, it's a wonderful way to take everything that happened on the inpatient side, transfer all that information to the doctor, make sure they have, if they don't have EMRs that talk to each other, make sure that medication list got from the inpatient to the outpatient. Make sure if there was any concerning symptoms once they went home, got taken care of. Did they get the home health set up that they needed? So these nurses call at about 24 to 48 hours after the patient's gone home. They follow up to make sure the patient went to their post-discharge follow-up, and then they follow them for several other weeks, making sure oftentimes that if they needed help getting medicines, they could set that up. We can find some resources in the community. If they need help with maybe getting cardiac rehab set up, maybe they're a new heart failure patient, getting them set up in cardiac rehab, maybe talking to them about MAC and the services that they offer and getting them set up with that. But that's what these nurses do, and they watch out for the patients, calling them weekly for about 30 to 45 days. Only the high-risk patients. Not every patient needs a nurse and needs that transitional support, but it has been exceptionally helpful.
So you call that a transitional care nurse, and that's for certain individuals that have a higher risk of coming back, readmission, as opposed to everyone pretty much has a care coordinator on that unit that's
Correct.
keeping an eye on their care, overseeing their care and discharge.
Yeah, and setting up anything that might be needed at discharge. So we have a case manager, and they're also part of this entire population team. The case manager is really there to make sure that discharge plan happens, but also on the back end to look at your benefits and make sure that your insurance company is actually going to support some of the services that we're setting up. So they're doing two things at the same time. It's a big job for all of these folks.
It is, and that's a big piece of it too, is the insurance. Now, what is the role of the physician in all this?
So on the inpatient side, the admitting physician is the one who's really taking that medical plan and helping us follow it through for the patient, making sure that the nurse is supporting that physician. On the outpatient side, especially with primary care, we really see them as sort of the brains of everything going on with the patient, kind of the quarterback, making sure that they know that the patient knows what to do, when to do it, and also where those referrals should be made, what other care and clinical services need to be supported. The nurse's role is really to help educate the patient, assess the patient for any needs that might come up in the interim between seeing the patient. But that primary care physician is really the quarterback to manage the care throughout the entire continuum.
And then there's that concept of accountable care organization. Maybe mention that briefly and what that means.
Yes, so here on the Eastern Shore, as part of Peninsula Regional, we have the Peninsula Regional Clinically Integrated Network. It's a Medicare Accountable Care Organization, or ACO. And what that is really a group of doctors who has said, yes, we want to work together to collaborate and coordinate care for all our patients. What it means for an individual patient is if I see you and you are a provider in this accountable care organization, then I know that you're committed to improving the quality across the board for all your patients, as well as improving my access to care. So the doctors all have an embedded case manager, and because it's new, it just started in January, we're just hiring those nurses and getting them up on board with the ACO. But there will be an embedded care coordinator in every practice to help manage folks who are struggling and need some more support if they have multiple chronic diseases or they're at high risk of breaking down or something going wrong. The doctors will be doing much of the referral for that resource, knowing that every patient doesn't need that, but many of the patients do.
Well, it sounds like optimally that'd be great for everyone, but for now you have to start small and just target the patients who have the most need or the highest risk for readmission.
Yeah, honestly, as a nurse, I think everyone could use a
Yes.
nurse. But there's a continuum. In our 20s and 30s, we're very active. As we get a little older, we may need a little more targeted support here and there. I think that's where programs such as MAC and some of the other community education, we've got diabetic educators at PRMC who do a phenomenal job of helping to do education for our patients. There's a lot of those resources that as we kind of start aging a little or perhaps have a new chronic disease, and then oftentimes as we find we have a challenging disease, sometimes a cancer diagnosis, that's when there's these nurse navigators or care coordinators come in for that targeted time to help us move through so we can get onto that better path to wellness.
And I know you mentioned this a little bit earlier, but let's elaborate on it a little bit, and that is the importance of collaboration. That's a hot term these days. Everyone wants to collaborate. The collaboration of PRMC with community agencies like MAC Incorporated. Maybe elaborate a little bit on that.
I think that is the key to population health success because, none of us can operate alone. The hospital obviously wasn't managing healthcare costs throughout the country on their own. An individual doctor wasn't managing on their own, and we really have to talk to each other. Patients only spend about 10% of their entire lives in the healthcare system. As we age, it's much more time, but if that's all the time that we spend, then how can we connect that time better so that we do communicate? Doctors have limited time. Nurses have such ability to support some of the referrals, some of the education, the assessment, some of these interventions within the community. Then we have physical therapists. We have pharmacists. Our pharmacy team at PRMC is doing so much work in the outpatient arena. They're educating every single patient as they get ready to transition from the hospital to home. They give them medication boxes. There's a lot going on with so many of our team members on the clinical side and on the administrative side that is just changing the way that healthcare is being delivered and making it truly collaborative.
Well, it sounds like collaboration between agencies and between disciplines, interdisciplinary collaboration, which is very important. So it sounds like the nurse in particular has a really important role here.
I think they do, and
we're both partial nurses, aren't we?
We're a little biased, but honestly, I think nurses have always had a role in the hospital, and nurses often didn't think that we didn't really think of nurses out in the community just helping doctors. But what they're doing is really, it's not even helping. It's a co-ownership of that patient. The nurse doing that education assessment, adding in interventions for the community resources and thing, while the physician's doing that true critical medical assessment part. But it's interesting, it's a time for nurses to really use all those skills we learned in nursing school, use all that assessment, and to be able to do it in various settings throughout that continuum of care. I know I started as an ER nurse, and I saw that brokenness in the beginning, but I couldn't connect the dots because a patient would either get admitted or they would go home. And so this is a role where we can really see patients get better, and we can see that whole continuum.
See, being a nursing professor of undergraduate students, some of these skills you learn in nursing school, but obviously you need some experience out there in the real world, taking care of patients and developing your communication skills and how to look at all the pieces and bring them all together to achieve a common goal. So it sounds like there's some great opportunities for nursing and for the hospital to really make a difference in the health of the community. So hopefully the end result of all this, you're saying, is better population health by, you're saying, building relationships, collaboration, and then identifying people that may have gaps in care. Does that about sum it up?
It does, and we have on our website, we've got our community health needs assessment that kind of shows where we are. We know that we're a more challenged, more rural population than others throughout the state of Maryland, but our real goal, not for today and not for 6 months from now, but our long-term goal is to improve the health of this community. And I think through population health and through this collaboration, coordination, and really stellar communication, I think we can do that.
Well, of course, I know that's one of the main missions of the hospital. So thank you so much, Kathy, for coming
Thanks so
on the
much, Mary.
program and enlightening us as to this new movement of population health.
Thank you.
And thank you for joining us for this edition of Focus on Health here on PAC 14.